So welcome, Dr. Lustberg.
Thank you so much, Jean, and thank you to the organizers as well as the wonderful audience. You're taking time out of your evening. I'm seeing all the comments and locations coming through. So thank you for joining us, and know that this will be interactive and hopefully we'll get some of your questions answered. And um, there's lots of resources that we'll share with you. I will share my slides. If you can just bear with me 1 second. Um, and let's do that. There we go. All right. So we have a big topic ahead of us with the goal of having a little something for everyone, because one thing that I will continue to emphasize throughout this talk is how each breast cancer has its very unique characteristics, and that you as an individual have your own special, unique circumstances in terms of what treatments are right for you and how you will tolerate these treatments. My disclosures are here and will not impact the content of what I will share with you. Jean alluded to the outline of the talk, which is that I hope to give you a broad overview of where we are with early stage breast cancer, and then talk more specifically about different subtypes of breast cancer. This is where some segments will apply to some of you at different junctures. And then we'll come back together again and just kind of talk about more general new discoveries in how we manage symptoms and side effects. And as I mentioned, we'll make sure to try to take as many questions as they come. So, talking about general trends in early stage non-metastatic breast cancer, we're referring to stage 1 to 3. Ductal carcinoma in situ is sometimes known as stage 0 breast cancer. Although I didn't specifically comment on DCIS in some of these slides, I think some of the things that I will talk about will also apply to stage 0. But our primary focus will be in invasive non-metastatic breast cancer tonight. And the good news is that advances in screening, and that includes mammography, ultrasound, and MRIs, as well as improvements in how we give therapies. This can include systemic therapy, optimizing our local regional therapies, including surgery and radiation, all have led to definite improvements in the survival of early stage breast cancer. In this plot here, you can see the breakdown by the different subtypes of breast cancer, and I will go in a little more detail in this next slide. We know that breast cancer peaks in our 50s and 60s, but really, as I'm sure some of you are in these younger age groups, breast cancer can absolutely happen in the younger age groups, and this is something that we are absolutely trying very hard as a scientific community, as an advocacy community, to draw attention to. Because younger women can absolutely develop breast cancer. And we're seeing actually a rising incidence of breast cancer in younger women. Regardless of the age group, the hormonally driven breast cancers tend to be more common. You can see kind of in these bar graphs. And we continue, unfortunately, to see disparities in how patients do, depending on their race. We continue to see worse clinical outcomes and survival in Black women. And lots of work is ongoing in terms of trying to understand these differences. As I talk about breast cancer, it's important to emphasize that it's not one cancer. There is tremendous heterogeneity, and we have different subtypes of breast cancer that we use clinically day to day. When I go see a patient, one of the first questions I ask myself and try to kind of share with the patient and her family is the subtype of breast cancer. And we routinely run 3 protein markers known as estrogen receptor, progesterone receptor, and HER2. And when you have very hormonally driven breast cancers that tend to be much more slow growing, they fall in this luminal A category. These tend to have lower proliferation, lower grade, and they tend to respond best to anti-estrogen therapies, and they tend to be less responsive to chemotherapy. But then we have some hormonally driven tumors that may have a faster proliferation rate, and these may need chemotherapy. We'll talk a little bit more about that. These are known as luminal B tumors. And then we have our less common but equally important breast cancers known as HER2 positive tumors. I like to think of HER2 as a growth antenna. It's normally present in all our cells. When there's a lot more of it, it's known as HER2 positive breast cancer, and that is about 15% of our breast cancers. And then we have the basal or triple negative breast cancers where all 3 markers, ER, PR, and HER2 are negative, and these are another 15%. So if we had to go by breakdown, 70% of our tumors are hormonally driven, 1/3 are HER2 positive, and 1/3 are triple negative. And the HER2 positive tumors may also have hormone receptor positivity. So we have 2 targets for those types of tumors that we treat. So those are kind of just a very broad overview in terms of the types of breast cancer that we see. I do want to highlight that we are beginning to do what we call genetic testing or germline genetic testing. Many of you have had this test where you have a cheek swab or a blood test looking for predisposition to breast cancer. There are now genetic panels that look for that. And what's interesting is that even in younger women, the majority of patients actually do not have a known genetic predisposition that we currently know of. But we are beginning to test a lot more women with breast cancer as well as men who develop breast cancer with these genetic panels. So this is called germline testing because it's your genetic makeup. But in contrast to metastatic breast cancer, and this is not a talk on metastatic breast cancer, but I do want to clarify this point. Currently, in early stage breast cancer, we're not doing genetic tumor profiling of early stage breast cancer. So you may find commercials or you may be reading articles where we're talking a lot about different estrogen receptor mutations or different genetic alterations in the tumor. I'm not saying that may not be the future of early stage breast cancer, but currently a lot of that type of data is in metastatic breast cancer and not early stage breast cancer. So I did want to clarify that. So let's start with the most common type of breast cancer, which is the hormone receptor positive breast cancer. And there's a lot to cover because with this being the most common type, there is so much research in this area, but I chose to break it down into 4 categories, and then we can also have additional discussions based on your questions. So starting with, we are doing less chemotherapy, and part of the reason we're doing less chemotherapy comes back to, we've all heard about personalized medicine, precision medicine, and it seems like, gosh, is this really happening? And what I'm here to tell you and emphasize to you is that indeed, due to advances in profiling tests, such as Oncotype DX or MammaPrint, we can directly test the tumor cells for sensitivity and really understand the biology of the tumor. So even though we're not doing kind of the type of genomic profiling that I mentioned in metastatic breast cancer, we have different tests in early stage breast cancer where I can actually take this report with me to a patient room and talk about, what we call the recurrence score, which is that validated number derived directly from testing your breast tumor after surgery. We can do it on biopsies as well, but in general, we do it most often on the surgical specimen. And then based on a validated algorithm, we can actually estimate what your risk of recurrence is at 10 years if you were to take some type of anti-estrogen therapy. It can be tamoxifen, it can be an aromatase inhibitor. And then this last box estimates your benefit from chemotherapy. So in general, if this score is lower, there's more benefit from endocrine therapy and much less benefit from chemotherapy. So the way I would interpret this report with a patient is that the good news is that you have a very hormonally driven breast cancer and that you do not benefit from chemotherapy. And this has really changed how much chemo we give. It used to be 20 years ago that any tumor that was 1 centimeter or larger would get some type of chemotherapy. But now about 2/3 of our breast tumors that are hormonally driven can actually be spared chemotherapy. And based on a large phase 3 data known as the responder study, we actually have data that this even applies to node positive breast cancer. If you have 1 to 3 positive nodes and are postmenopausal, we can use this type of testing to potentially spare you chemotherapy. So this is really important assay that we use all the time. And mammoprint similarly, similar idea. Tumors are classified into low risk, high risk, or ultra high risk, and this is critically important for clinical decision making. And for younger women, because a lot of these data were validated in postmenopausal women, and there always has been a question of, can we use this similar type of data in younger women? And this is something that is the subject of active investigation. This offset study is a large National Cancer Institute sponsored study, which is asking the question of, let's take premenopausal women with early stage breast cancer, and if their oncotype recurrence score is lower, they essentially can be randomized to receiving maximal hormonal suppression using shots that suppress their ovaries. They have the option of having helper therapies added to the anti-estrogen therapies, and we'll talk about those in a second. Or they may be randomized to chemotherapy. And you may be thinking to yourself, who would ever agree to be randomized on chemotherapy? And I think it takes a wonderful patient who's willing to do that. But it's the reason that the randomization is happening is because we're not sure that chemotherapy is truly needed in this favorable biological group. And the only way that we can definitively reach that conclusion is through this type of study design. So this trial is ongoing. A little under 100 patients have enrolled so far, and this is a critically important study for breast cancer. I get this question quite a bit, which is, there is so much in the news about immunotherapy, and a lot of my patients with hormone receptor positive tumors ask me, well, what about us? Is there an option for immunotherapy? And so right now, immunotherapy use in early stage breast cancer is being tested in clinical trials. We used to generally think that hormonally driven breast cancers did not really benefit from immunotherapy, that they were kind of what we call colder tumors. They were not really immunogenic enough to benefit from chemotherapy. But as studies have been done, what they have shown is that there is a subset of hormonally driven tumor that actually have an immunogenic profile. And the way we find out which tumors have this immunogenic profile, it goes back to testing the tumor, particularly that mammoprint test. If there's a subset of tumors, about 1/3 of these hormone receptor positive tumors fall in that high 2H2 tumor category. And what studies have shown is that based on studies such as I-SPY 2, there was also a Keynote 756 study that was resulted where patients with hormone receptor positive breast cancer. Some of the patients received immunotherapy, others received standard chemotherapy, and particularly in tumors that tend to have lower expression of hormone receptor positivity, or tumors that kind of have this more immunogenic profile, immunotherapy may actually significantly improve response to chemotherapy. So there is an ongoing phase 3 study currently ongoing that's evaluating this very question. So I would say most patients with early stage breast cancer are not receiving immunotherapy, but there is some important work going on in the context of clinical trials. We know that when I talk about endocrine therapy, I just want to clarify that there are multiple terms that are used to describe endocrine therapy. This includes anti-estrogen therapy. Sometimes it's referred to as hormone therapy, which can be confusing because it sounds a little like hormone replacement therapy, which is not what we're suggesting here. But just know that when I'm referring to endocrine therapy, I'm talking about some type of estrogen blocking or estrogen reducing therapy. And cannot impart enough the importance of this in hormone receptor positive breast cancer. This is the target. This is what's driving these tumors. But what we have also learned is that to help the endocrine therapy work better, if you can think back to your biology class, tumor cells go through mitosis. That's another fancy way of saying that the tumor cells kind of learn to divide and replicate their DNA or genetic material. What if we had elegantly derived pharmacologic therapy, prescription medications that actually stopped the growth of cells in this G1 phase, which is part of that cell cycle? So a good way that I've seen this explained by my colleagues, and I've adopted it, is that think of it as a brake. Essentially, what if we put the brake on the tumor cell growth and kind of made them freeze in this growth cycle? Then the anti-estrogen therapy or endocrine therapy can actually work better. And so as a consequence of years and years of research, essentially three drugs were developed. Two of them are approved in early stage breast cancer that essentially block this growth pathway. And if we're kind of putting the brakes on and preventing these proteins that are critical for the cell to progress through the growth cycles, we have drugs that are known as CDK4/6 inhibitors. So they're inhibiting the pathway. And by inhibiting the pathway, we're arresting the tumor cells. And the first drug that was approved in early stage breast cancer is known as Verzenio or abemaciclib. And then in the last year, we had a second drug approved known as Kisqali or ribociclib. So these are two agents that we now are routinely using in early stage breast cancer that has some high risk features. We're not using it for the earliest stage 1 breast cancers, but for tumors that are showing evidence of lymph node positivity or evidence of a more aggressive biology, these are approved, hot off clinical trials and ready for use. Verzenio is used for 2 years along with endocrine therapy, and Kisqali is used for 3 years along with endocrine therapy. There are patients that are eligible for both, and we do shared decision making, reviewing different side effects, and we decide together which one to go with. There are patients who may be a little bit earlier stage but have high risk features that may only qualify for Kisqali. So it's something that has really changed this immediate survivorship period, that acute period of kind of coming off surgery and radiation, where we used to say, go take your endocrine therapy. Now we have these smart pills or targeted therapies. And what the studies have shown is that they reduce recurrences. And ultimately, we expect that these drugs are going to show a survival advantage. So really important drug. They do have some toxicities that we actively manage with our patients, but really important in terms of keeping the early stage breast cancer patients from progressing to metastatic disease. So if you're a candidate for these, I think it's a really important set of drugs to keep in mind.
Dr. Lustberg, I'm just going to jump in with a few
Yes.
questions.
Yes.
I'll try to stick with what you've already presented. So one question is, what are some of the side effects of the CDK4/6 inhibitors?
Yes, really important question. So the number one thing that's reported by patients is actually tiredness or fatigue. So this is something that we manage. We know that reducing the dose of the chemo if fatigue is very bothersome actually has not been shown to impact the efficacy of these targeted therapies. So dose modifications, I do want to say, are a very active part of our managing side effects with these drugs. With Verzenio, we also manage diarrhea actively. I think it's absolutely possible to manage diarrhea by proactive measures of taking Imodium or loperamide at the earliest onset of diarrhea. And if it's not responding, again, dose reductions can really make a difference. With Kisqali, we watch out for liver function test changes, as well as lowering of the white count. And again, we may hold the drug and then resume at a lower dose. So those tend to be the most common side effects that we watch out for.
Great. And another CDK4/6 question is, how did they decide that 2 years was the right amount of time to take these drugs? I think this person might be a little bit nervous. Is that really enough time?
Oh, great question. Great question. So whether 2 years or 3 years, so the Monarch E study with Verzenio was set for 2 years. The Natalie study for Kisqali was set for 3 years. So a little bit of that is based on the biology of hormone receptor positive breast cancer and the idea of what we call minimal residual disease, which I have a slide on coming up, which is that there may be tiny microscopic cells in the blood that we can't see or measure clearly, although we're getting better at that. And what if we kind of use these smart pills to try to eliminate that early evidence of minimal residual disease? And the 2 to 3 year mark is thought to be that time period where we sometimes see those early recurrences in hormone receptor positive breast cancer. So that was part of the rationale. But to your excellent question of, well, is that enough? What we have maturation data for the Monarchy study that shows that even after the drug was stopped after 2 years, patients who received it continued to do better. So it's not that the drug was stopped and suddenly, recurrences started to go up. So the idea is that that early proactive intervention on minimal residual disease can potentially change the biology of recurrence. So we do think a couple of years is definitely enough time.
Okay, that's a great answer. I'm going to ask there's several questions about aromatase inhibitors. So I'm just going to kind of lump them into one, and then I'll let you move on with your presentation. A lot of questions about, can you stop it early? Can you completely avoid it? How the side effects are difficult. And then also, why is joint pain a side effect of some of the AIs?
Yeah, great question. So let me start with the last one. So the best way we understand is that estrogen is a natural lubricant for our joints and tendons, as well as our vaginal tissue. So as we essentially what aromatase inhibitors are doing is they're blocking the aromatase protein, lowering effective body stores of estrogen. So even though they're at low levels in postmenopausal breast cancer, we're making them go even further lower. And so in this very low estrogen state, everything feels stiffer. So what you may be experiencing is when you wake up in the morning, it takes longer to warm up, and things can I've done work in this area where if we image the joints, we can actually see inflammation. So there may be actually an element of an inflammatory arthritis that's not a rheumatoid arthritis, but just the joints in this low estrogen state may have evidence of inflammatory changes. And so whether you can take it or not. So pretty much all our studies to date have studied these for a minimum of 5 years. We do have studies in non-invasive breast cancer with tamoxifen for 3 years now, but really all our data right now in aromatase inhibitors is with 5 years. Whether you can stop or not, I think is a personal decision based on the stage of breast cancer. I think if you have an oncotype report, actually seeing your actual benefit from endocrine therapy can help in your decision making. So what this plot is saying is that if you were to not take the aromatase inhibitor or tamoxifen, this number jumps to about 10%. So there are tumors where this number may be 2%, and then essentially you double it because that's an approximate benefit from endocrine therapy. So I think if you've taken it for a few years, there's also an additional test that I didn't make a slide for called the breast cancer index. Can also help you and your doctor decide whether there's any benefit to extension of therapy. There is a good amount of data that taking a hold for a few months to let your inflammation and joint symptoms get better is absolutely feasible and does not seem to impact recurrences. And then when we switch to aromatase inhibitor, about half the times patients seem to derive benefits. So I think it depends on a few things, but don't be afraid to discuss it with your doctor in terms of what your expected benefit is, and also whether discontinuation or therapy switch is an option. So not a one size fits all answer, but don't be afraid to bring it up if it's hurting your quality of life. And there's a quick question on tamoxifen versus osteoporosis. So tamoxifen is bone protective. So I think if you have osteoporosis, it's absolutely something that I tend to favor tamoxifen for the right patient with osteoporosis, but also know that there are bone building medications that can be used to manage osteoporosis. There's been great advances, tremendous advances in terms of testing the blood for what we call that minimal residual disease. There have been multiple blood-based biomarkers over the years, including tumor markers and circulating tumor cells. But I think the latest variety is known as circulating tumor DNA. And the idea is that tumor cells shed fragments of DNA in the blood. And due to advances in technology, we're able to detect these now. And there are multiple different assays out there, including, blood tests that are specifically formulated to your primary tumor genetic makeup, and are essentially looking for those tumor fragments in your blood. And then there are also circulating tumor DNA tests that are in development, and some of them are available now where they're not based on testing your initial tumor, and they can essentially detect fragments of abnormal DNA in the blood. And so lots of patients are asking about these tests. I think it's an important advance in that we're able to continue to improve on this technology. We do know that they do give us clues in terms of what may be happening, and there may be a sign that a recurrence may be in the horizon. Now, there's still a chance for false positives and false negatives, but they do appear, at least particularly for hormone receptor positive breast cancer, they may be a sign that late recurrences may be something that could happen later down the road. And then I'll talk about it in the context of triple negative breast cancer coming up. We can go to the next slide. And so there's a number of studies that are looking at this question, and I'm not going to cover all of them, but this particular one is in partnership with Manorini, Personalis, as well as the Translational Breast Cancer Consortium, where we are actually taking patients who have completed their endocrine therapy for early stage breast cancer, testing their blood, and if there's evidence of circulating tumor DNA, they have the option to enroll in the study and essentially get a novel anti-estrogen therapy known as elacestrant, which is another newer type of estrogen degrader pill. So lots of studies like this are in the horizon. Next slide. And I get, and you guys are able to see the slides correctly, correct?
Yeah, we can see the slides.
Okay, great. So then there's another larger study called the Elegance study, which is taking patients who, again, with early stage breast cancer with high risk features. And then the idea is, do we want to change up our traditional endocrine therapy agents where we know that sometimes resistance can happen? And for this is a population of patients where they have the option of potentially receiving new anti-estrogen therapies. And all of this, the theme of this is in hormone receptor positive breast cancer, we're trying to derive newer ways of addressing what we call late recurrences, recurrences that can happen years down the road by really understanding better who's at risk and can we essentially target them with newer therapies. Next slide. Um, and so this is a little bit of a busy graph that shows you that lots of activity in this early stage hormone receptor positive breast cancer looking at new drugs. So we've talked about tamoxifen, we've talked about aromatase inhibitors, but there are a new set of drugs known as SERDs or selective estrogen receptor degraders, and lots of trials are trying to answer the question, perhaps introducing these new drugs either in sequence or in place of your traditional tamoxifen and aromatase inhibitors, can we more effectively reduce recurrences in hormone receptor positive breast cancer? Next. Next slide. And so I know we had a little interruptions with hormone receptor positive breast cancer. I know there are probably a lot of questions that we haven't gotten to. Jean, should I go on to triple negative, or are there questions you wanted to ask right now?
I think I'm going to let you go to triple negative, but I did want to ask one question because I know that the information you just shared on the Signatera test or
Yep.
circulating tumor DNA, and there's also Guardant Reveal.
Yep.
If people listening want to go talk to their doctors about this, when is the time to do it, and
Yep.
who should be asking?
So first of all, my message to the audience and patients is absolutely you're right to ask these questions, and that I think your oncologist should absolutely hear your questions, hear your concerns. I would say that oncologists, depending on which camp they're in, there is, our national guidelines and national societies are recommending caution right now in terms of routine use of circulating tumor DNA test. Because what we know is that we know that they're promising. There's absolutely no question about that. And I really do think they're going to change the face of how we practice oncology in the future. That's my personal belief. I think at this present moment, the concern or hesitation by many oncologists is that if there is a positive result, we will scan you up and down. We may not see anything. Outside of a clinical trial, we actually don't know what exactly to do with that positive test result. So it may cause additional anxiety. It may not, but this is the concern. That we have a lack of clarity in terms of how to utilize those positive test results. So what do I do in my practice? I tell my patients that I may not know what to do with those positive test results. And there are many patients who say, I don't care. I want the test. I want to have as much information as possible. And I think that's exactly where we should be landing with our patients, that shared decision making, letting them know that this technology is there. We're still learning about it, but to have those discussions about pros and cons for each individual case.
Great. Let's get to triple negative.
All right, you can advance the slide. So this is about the 15% of our breast cancers, and I'm going to talk about some of our newer trends in triple negative breast cancer. If you go online and if you've done research on triple negative breast cancer, I know it can sometimes feel terrifying because a lot of the literature does paint a grim picture about triple negative breast cancer. But I'm here to tell you that particularly for early stage breast cancer that's triple negative, we have made a lot of advances. So moving on to the next slide. So one is with immunotherapy. So this was the first type of breast cancer that got approvals for immunotherapy. These are checkpoint inhibitors, Keytruda or pembrolizumab, and they absolutely have changed the face of triple negative breast cancer. What we have learned through the trial known as Keynote 522 is that when I add Keytruda to traditional chemotherapy, a larger number of patients, almost 14% more, are able to achieve that complete pathologic response. If a patient receives a complete pathologic response with preoperative chemotherapy, the chance of recurrence from triple negative breast cancer is extremely low. So it really improved outcomes and led to the approval of Keytruda in early stage breast cancer. Next. And an additional advance has been a group of drugs known as antibody drug conjugates. And this cartoon illustrates that it's not that they're not chemotherapy. I like to think of them as their smarter way of delivering chemotherapy. So you have essentially you target a protein on the tumor. It could be HER2, it could be TROP2, it could be any number of markers on the tumor, and that antibody is linked, that's the linker, to the actual chemotherapy that then gets released inside the cell. Some folks have referred to these as the Trojan horse model of delivering chemotherapy. You kind of sneak in and deliver your soldiers after you're inside. And so this is showing tremendous promise in triple negative breast cancer particularly, but also applies to other subsets of breast cancer as well, including hormone receptor positive in the metastatic setting, as well as HER2 positive breast cancer. But the reason I chose to highlight ADCs in the triple negative breast chapter is that we're actually doing studies right now in early stage breast cancer for patients who have not had that complete response to chemoimmunotherapy. Then at the back end after surgery, there are candidates for these antibody drug conjugate therapy. So we have a lot of hope that these drugs will help improve cure rates in triple negative breast cancer. Next. And so back to the circulating tumor DNA story. The story is even more evolved, I would say, in triple negative breast cancer. We have a body of data that shows that if we can detect circulating tumor DNA, particularly after surgery, after completion of that preoperative chemoimmunotherapy, if we're able to detect circulating tumor DNA, that may mean that we're seeing a potential for a higher risk of recurrence. And this is not meant to scare anybody in the audience who may be experiencing this. There are patients who may not experience a recurrence. So all of these are probabilities. They're not meant to predict your particular course, but it's something that, study after study has shown that if we can see it, particularly in that post-surgical period in triple negative breast cancer, these are the patients that we need to focus more on. We need to target them better. We need to have them enroll in more smarter clinical trials. So I do think this will really, again, change our ability to improve cure rates if we're better able to pluck out the patients who are more likely to have recurrences. So this will lead to better delivery of systemic therapy. Next. And, we've talked about escalation of therapy up to date so far in terms of triple negative breast cancer, that, we're giving, immunotherapy, we're giving antibody drug conjugates. But I also wanted to mention that not all triple negatives may not need more therapy. We're learning that if the tumors have these immune infiltrating cells known as tumor infiltrating lymphocytes, we can actually test for these now. If they have a lot of these triple negative tumors actually can have very favorable biology and may not need as much treatment. So there's actually going to be a trial investigating that, where patients who have a lot of tumor infiltrating lymphocytes may be actually spared harsher chemo, We're absolutely conducting trials where we're using less anthracyclines in triple negative breast cancers, avoiding chemo in very small tumors. And for patients who have germline alterations, BRCA1 and 2, there have been several exciting trials that have looked at using PARP inhibitors and immunotherapy in place of the traditional chemotherapy. So these are some of the newer trends that are happening in triple negative breast cancer. Next. And so, any quick questions on triple negative breast cancer before I move on to HER2 positive?
There's not any specific triple negative questions, but a lot of questions about if you are hormone positive or HER2 positive or triple negative. If there is a recurrence or if it becomes metastatic, can it change? Can the subtype change?
Yes, 20% of the time it can absolutely change, which brings up the point that it's really important not to assume that it's the same subtype of breast cancer and definitely have tissue biopsy confirmation of that recurrence. And there are also times where what is thought to be a recurrence ends up not being a recurrence. So definitely tissue confirmation is really, really important.
And then there's one triple negative question. So I'm going to ask that and then we'll go to the HER2 positive. But this person's asking, why are these newer drugs only for stage 2 or stage 3?
Great question. Really important question. So, so it has to do with kind of the recurrence patterns that we see in triple negative breast cancer. In general, stage 1 triple negative breast cancer does quite well without a lot of treatment. And so these are very small tumors. We tend to treat them with surgery first, and then they typically get a shorter course of traditional chemotherapy. It's these stage 2 and stage 3 breast cancers that if we look at survival curves and recurrence curves, those tend to have the highest levels of recurrence relative to stage 1. And so this is why the standard of care has been that if it's stage 2 or 3, we want to do that preoperative type of approach. So we can actually see if your tumor is responding. And if it's not, then we can do additional therapy at the back end. The concern for treating stage 1 tumors like this is that it will actually, since they do well regardless, that it may end up being over treatment and additional toxicity for really no benefit. So that's the reason.
Okay, keep going.
All right, HER2 positive breast cancer. So lots of advances in HER2 positive breast cancer. So we can go to the next slide. And the idea that I think, we talk so much about clinical trials and scientific discovery. And I think out of all the breast cancers that I've covered, the story of HER2 positive breast cancer is truly a story of amazing human innovation and discovery. When this Herceptin was discovered, which is an antibody that targets this HER2 protein, it completely revolutionized. We used to talk about HER2 positive breast cancer as the worst, most aggressive type of breast cancer, and now it has become really, truly one of our most well-treated and well-behaved types of tumors as long as it receives HER2-directed therapy. And so in that plot, you see a series of various milestones. There have been a lot of amazing drug development in this area, and we'll cover some of these. And they have completely, when I see HER2 positivity in a tumor, this is one of those funny things oncologists say, but I actually feel great excitement that I have wonderful drugs to give my patient. Next. And so the theme with HER2 positive tumors is that we've really learned to do much less harsh therapies. We used to give a lot of adriamycin, which is part of the class of anthracyclines. And when we would give adriamycin and then we would give Herceptin, patients had higher rates of heart failure. But what we learned through dedicated clinical trials is that we could eliminate the anthracyclines and patients would do just as well and have less cardiotoxicity. So this has become really the standard of care. Um, my boss, Eric Weiner, was one of the pioneers who really asked the question that for these really small stage 1 HER2 positive breast cancers, we don't really need multi-agent chemo. We could essentially pick one chemo, Taxol or Taxotere, and combine it with Herceptin. And the vast majority of patients can do really well with this much shorter, much less toxic regimen. And the third piece has been that even for stage 2 and stage 3 breast cancer, we're beginning to kind of get away from adding too much chemo on the front end. So standardly, we give Taxotere plus Carbo plus Herceptin and Perjeta. There's mounting evidence that we can eliminate one of the chemos known as Carbo, and patients can do just as well. Next. So, but there are times when patients do need more therapy. And so for patients who don't have that complete response to preoperative chemo, similar to the triple negative breast cancer story, the targeted drug known as Kadcyla or TDM1, giving 14 doses of this drug for 3 weeks after surgery has been shown to dramatically improve the number of patients who are able to achieve a long-term cure. In addition, we are adding additional targeted therapies to drugs like Kadcyla. And so Takeza or tucatinib is a smart oral targeted therapy that's currently approved in metastatic breast cancer. But now we're testing it as part of a clinical trial in early stage HER2 positive breast cancer. And so in this clinical trial known as Compass Residual Disease, half the patients get Takeza in combination with TDM1, and half the patients get simply the standard, which is TDM1. And one of the reasons that the Takeza story is important is that it's a small molecule, so it can potentially penetrate the brain tissue much more effectively than TDM1 and Herceptin, and help prevent or reduce the chance of future brain metastases. Next. And you will hear a lot of headlines in this year's ASCO. They're calling it ASCO Breast because there's going to be a lot of headlines. And one of the headlines that you hear about is I introduced the idea of the antibody drug conjugate or ADC therapy. Well, this was an early stage HER2 positive neoadjuvant therapy that used a HER2 ADC. And what they found that in this HER2 ADC known as Enhertu, when given upfront, actually compared to traditional preoperative HER2-directed chemo approaches, led to higher complete pathologic responses. So we're going to see the full data in this year's coming ASCO, which is going to be in the few weeks. So I think so essentially the theme that I hope you can also take away with you in terms of new emerging therapies is that we're going to see a lot more ADC therapies emerging in this early stage breast cancer space. Next. And so you may have heard about HER2 low because we've been talking a lot about that in the metastatic breast cancer space. So I wanted to make sure to touch on that. So you can go to the next slide. And so, we've talked about these antibody stains and immunohistochemistry that we do on tumors. And you can see on the left-hand side, if a tumor has a lot of HER2 protein, it's going to stain, dark and brown, as you can see on top. If it has no staining, that's at the bottom, nothing picks up. But a good proportion of tumors that are hormone receptor positive or even triple negative breast cancer actually can pick up low levels of HER2. And these are known as HER2 low. And there's even a new category now known as HER2 ultra low, which is just a tiny bit of staining. So I wanted to at least introduce this category with the caveat that right now we're primarily using HER2-low to direct patients in the metastatic setting. We're not ready yet to use this as a biomarker in early stage breast cancer. But one of the rules of breast cancer talks is that your talk is outdated within 6 months. So stay tuned because I think this is a rapidly evolving area. And but right now the takeaway is know that the HER2-low category exists. You can find out what your HER2-low category is. You just have to find your initial pathology report. And as long as it's 1+ or 2+ by immunohistochemistry and it's FISH negative, you're actually HER2-low. So it's fine to know the information, but know that we're not currently acting on that information. Next. And so essentially what I said, so not using it yet, but I wanted to make sure that you knew about it. And questions here that I want to make sure I'm answering the treatment questions before we move on to anything in symptom management. Jean, anything you wanted to ask right now?
Yeah, I'm not seeing any HER2 positive questions. I mean, there are a lot of questions. So why don't you keep going and then
Sure,
we'll
sure,
just run through the
sure.
everything.
Okay, next, we can go to the next. So I wanted to really take a moment to highlight that the right therapy is critically important, but to make sure that you tolerate that right therapy, we want to make sure that we're taking care of all of you and that we are really trying to minimize toxicities as much as possible. And so the two go hand in hand. It's not either or, it's and. So moving on to the next slide, I wanted to really highlight some exciting developments in early stage breast cancer, looking at optimizing metabolic health. The Be Well study was over 3,000 patients with early stage breast cancer who were overweight or obese, and they were randomized to targeted coaching for weight loss. And so lots of important patients were able to lose some weight, and there were important markers of improved metabolic health. So you'll be hearing just continued importance of optimizing metabolic health in breast cancer survivorship. Next. But how do we do that is the issue. And I think we all have busy lives and it can be very hard to know exactly what type of things to eat. And in general, we talk about a plant-forward diet, less processed foods. And this is a study that I'm leading with my colleague who is a PhD level dietitian. And so this study is available free of charge for any of you who may be eligible. You can just scan the QR code and it's free virtual nutritional support for you. Next. And then the question of breast cancer and pregnancy, I think for the first time we had the landmark positive study readout in the last 2 years, which showed that pregnancy after breast cancer is possible and safe, and that even if you're on ongoing endocrine therapy and you haven't finished your 5 years or 10 years of therapy, you essentially, if you've taken it for a few years, you can have a 3-month washout, attempt pregnancy, have your child, and then return back to endocrine therapy. So that we finally have prospective global data on this approach. Next. And I also wanted to, there's a lot of attention now on GLP-1 agonists and weight loss drugs. And even though patients with breast cancer were initially excluded from GLP-1 agonist clinical trials, I do want to say that there's a growing body of retrospective data that is suggesting safety in breast cancer survivors. So definitely, based on your metabolic health needs, have that discussion with your doctors in terms of if you need to use pharmacological therapies. We do not currently have any contraindications in breast cancer.
I'm glad you mentioned that because a question just popped up.
Yes.
So thank
Yes.
you so much. I'm
Yes.
just gonna, if you're okay, I'm just
Yes.
gonna This will be just questions all over the
Yes.
place. So the first one is, what if you're ER positive and HER2 positive? So you have, you have two different types of breast cancer. Is there anything new, or is it just the combination of everything you talked about?
So we initially target the HER2 pathway most strongly. So initially you would get the right type of chemo HER2 combination. And then for your maintenance therapy, introducing the endocrine therapy agent, whether it be tamoxifen or aromatase inhibitor, we would do that similarly. CDK4/6 inhibitors, we do not have data for early stage HER2 positive breast cancer, but we do have data now for HER2 positive metastatic breast cancer. So stay tuned, but right now, endocrine therapy alone for what we call triple positive cancers.
Okay, great. Thank you. Um, there are a lot of questions about who is eligible for a CDK4/6 after their primary treatment, what stages. And there are some people here that have lobular breast cancer, and I think there might be confusion. Is lobular a subtype or is it something else? So if you could do both of those.
Sure, sure. There are many different histological subtypes of breast cancer. So ductal is the most common histological subtype. So that's a pathologic diagnosis in terms of where the cancer cells originated. Was it the milk ducts or was it the lobulars or lobular tissue, the lobule milk sacs? So in some ways, yes, lobular cancer is a histological subtype, but in terms of the traditional prognostic subtypes, kind of typically falls into luminal A, luminal B, hormone receptor positive. But there are exceptions. There are even times where we rarely see triple negative lobular cancers, or we may see pleomorphic HER2 positive lobular cancer. So great question, but I think the biological subtypes that I presented apply to all histological subtypes. And in general, all the treatments that I talked about, lobular cancers tend to need less chemotherapy, but really benefit from that smarter endocrine therapy, targeted therapy approach, even though the original trials did not break things down by histological subtype. We know that lobular cancer tends to really benefit from endocrine therapy. So yes, so definitely. So in terms of eligibility for CDK4/6 inhibitors, so there are wonderful tables that I can maybe share with the organization to kind of pass out to patients so that you can see clearly. But I think the simplest way of describing it is pretty much at this point between the two drugs. If you have lymph node positive breast cancer, you're essentially eligible for one or both of the CDK4/6 inhibitors. If you're lymph node negative and have one additional high risk feature, that may be that you have a high proliferation rate in terms of a high Ki67, or you have a high grade tumor, like a grade 3 tumor, or you have an oncotype recurrence score of 26 or higher. If you have one of those high risk features and you're node negative, you are eligible for Kisqali.
Okay, so it sounds like you should have a conversation with your doctor about this to find.
Yes.
Sorry, when I mean, you might not know the answer to all those questions. Okay, some people are confused when you talk about a germline mutation. Can you explain?
Yes, yes.
Thank you.
So by germline, we talk about what makes gene, what is the genetic makeup. So this is something, these are building blocks that get passed down from parent to your children. And so they are genetic factors that get passed down. They're inherent to you. It's what makes you you. So classic hereditary breast and ovarian cancer syndromes tend to be positive in BRCA1, 2, PALB2, but there are others as well. But when we talk about tumor genomics, this is known as somatic tumor genomics. And so this is not your genetic material. A tumor is essentially a foreign entity in your body that has learned to live inside you. And so So when we talk about tumor sequencing or interrogating the tumor, this is different than your genetics. This is particular building blocks of the tumor that makes the tumor grow and proliferate.
Great, thank you. We always get that question, so it's good to just say it over and over again. I appreciate it. And similarly, we get this question a lot also. If you're triple negative and you're a BRCA1 carrier, or are you more likely to have a recurrence?
So in terms of distant recurrence, your chances of distant recurrence are very much driven by the stage of the triple negative breast cancer, how well your response was to the preoperative treatment, if that's what you ended up having, and having the BRCA alteration does not necessarily make you have worse prognosis. In some ways, it may make it better because selected patients are also candidates for adjuvant PARP inhibitors in that setting. But in terms of local recurrence, you do have a choice in terms of whether you choose to have bilateral risk reducing mastectomies or you choose to do intensive surveillance with alternating mammogram and MRI. So for those patients who elect to keep their breast, yes, having those hereditary alterations like BRCA1 and 2 does elevate your lifetime risk of a new breast cancer developing even after definitive treatment for triple negative breast cancer.
Okay, great. Thank you. You didn't talk about Neuralinks, but could you talk about Neuralinks versus Kadcyla?
Yes, yes. So Neuralinks is another smart oral targeted therapy, Neuralinks or neratinib. So the ExoNet study essentially studied high-risk patients, and essentially a year of oral targeted therapy was shown to reduce recurrences as well as reduce the incidence of brain metastases. So the idea is that these smart HER2 targeted therapies have better brain penetration. Those data were generated in terms of one of the things that can happen in breast cancer is that data continue to evolve. So sometimes we don't know where therapies might fit in the context of new therapies. However, for certain high-risk patients who are not eligible for kind of oral targeted therapy on compass residual disease, I'm absolutely using that and having a discussion with my higher risk HER2 positive patients about the potential benefits of Neuralinks in that setting after they have completed kind of the year of HER2 directed therapy.
Okay, great. We're just going to do a few more questions because I'm sure you've been in clinic all day. But there's a couple of people who I think are concerned now because they say they never got an Oncotype score. They may have gotten it and don't know it, but are there certain people that just are not eligible for Oncotype DX?
So the extremes, and I don't want to talk about anybody
Yeah.
as an extreme, so forgive that terminology. But if you had a very, very small tumor that was grade 1, which it's a grade is different than stage. So grade 1 tumors tend to be very slow growing. So these really small few millimeter tumors that are grade 1, we need the tumor to be at least half a centimeter. And so it's a discussion with your oncologist in those settings, whether we want to send it on these very small tumors. Similarly, if you have stage 3 hormone receptor positive breast cancer, we're beginning to use Oncotype testing a little bit more in this setting, but it's sort of at our data limits because the responder trial really focused on patients who had up to 3 positive nodes and not more. There is going to be a larger study mounting for kind of these higher anatomic risk patients and using Oncotype in decision making. But I would say if you had very early stage 1 or a stage 3 breast cancer, you would not have officially met criteria for Oncotype.
Okay, so don't be panicked. You can always ask your doctor. It might be in your portal and you don't know it.
Yes.
I'm going to ask you just 2 more questions. There is a question saying, what if you're very ER/PR positive, like you're just an exceptionally high? Is that good, bad?
It's exciting. It's good. Like it sounds, these are weird things oncologists say, but having a strongly ER positive tumor means two important things. One, these tend to be are well-behaved, slow-growing tumors. They tend to have just the best prognosis. And two, they derive a lot of benefit from our endocrine therapy agents. So to two bonus areas there.
Great. That's good because sometimes people get worried, like, is it good or it's bad?
Yeah.
I'm just going to ask this because it concerns me, but that someone is asking, is it true that some grade 1 breast cancers can be resolved naturally by the body?
We're beginning to study this, and this is not permission to not go out there and treat grade 1 tumors, but I think it's an important question suggesting that we are beginning to there are most of this work has been done in ductal carcinoma in situ. So the COMET study kind of looked at potentially observation on endocrine therapy and not doing surgery. But I think what you're asking is, could there be grade 1 tumors that are small, so indolent that they may not need a lot of therapy, and perhaps we've been over treating them? Right now, we're not smart enough to know which grade 1 tumors are in that camp, where which grade 1 tumors are in the camp that need at least a little bit of therapy. But I think this is going to be changing. Don't go stopping your endocrine therapy now, but know that we're actively working on being smarter about picking out the bad players from the good players. So we are committed as a breast oncology field to answer your very important question, but we're not ready yet.
Great. And I want to thank you for both showing de-escalation of treatment, new treatments, and also having a couple of slides on nutrition and, other things that you can do to sort of increase your health and, hopefully prevent cancer from coming back.